those are our 3 administrative districts. We have Emakhandeni district, we have Nkulumane district in blue, and northern Emakhandeni district is the one that is in light purple, and then the northern suburbs district is the one that is vast, which is in lilac. I hope I'm not colorblind. Huh? Those are the colors. And then we also have our health facilities. We have northern suburbs. Under northern suburbs, we have TF Watson, we have Entumbane Clinic, we have Mziligazi, we have the northern suburbs and Princess Margaret Rose Clinic. And under northern suburbs, we also have our central hospitals. And then in Nkulumane, we have Dr. Shannon McCowan, Keta, Nkulumane, Penandara, and Chavala. So in Nkulumane district, we have 6 health facilities. And then Emakhandeni district, we have Cowdrey Park. Cowdrey Park is actually 3 in 1. Because it's also quite vast. And then Emakhandeni, Luveve, Makweko, and Juvia, Kumula, and Kumula South. So those fall under Emakhandeni district. So when we talk of our administrative districts at the city of Bulawayo, this is what we are using. And then when we're talking of coronavirus, it's a large family of viruses which cause a wide range of diseases, such as the common cold, Middle East respiratory syndrome, and the severe acute respiratory syndrome, SARS. So it's a new strain, the SARS-CoV-2 is a new strain of coronavirus. I'm sure this is not new. We've been having this since 2019. And then the symptoms actually vary, and they've been changing ever since because of the mutation of the virus. But the common ones are mainly mild fever, cough, fatigue, shortness of breath, and myalgia. Those are muscle aches. Anyone can become sick with COVID-19, regardless of age and health status. I'm sure you've actually seen that in the community. And the people above the age of 60 and those with underlying medical conditions are more at risk. So what we've also discovered is that most of our admissions are the people that have underlying conditions. And recently we also did an analysis of our admissions with regards to Covid-19 vaccination. And those that get severe symptoms are those that are not vaccinated. And then for the complications of Covid-19, they include severe disease and may lead to death. So Covid can actually kill. I'm sure you've also noted in our national situational report with regards to Covid-19. So the vaccine is actually coming as an important protection for Covid-19. We've got various Covid-19 prevention protocols that we've been talking about. And the Covid-19 vaccine came in as an additional prevention measure. So who is at high risk of severe Covid-19? Like I said earlier on, it's people above 60, but in general, everyone is at risk. Everyone is at risk. I'm sure you can remember, especially for our reporters, where we've been having schools being closed or turned into isolation, quarantine centers because of COVID-19. So everyone is at risk, but those that are at high risk are mainly the elderly with chronic diseases like high blood pressure, the heart diseases, the diabetic patients, and those with chronic kidney diseases. So we've also done an analysis as well in our admissions, and this is what we actually came up with. And those that are obese, and then those that are HIV positive, those that smoke, and those that are pregnant, those with liver disease, those with anemia, chronic obstructive pulmonary disease. And then the mortality ranges from 5 to 10% for people with the above conditions. And then COVID-19 also causes very significant morbidity and mortality, causing pressure on healthcare systems and also socio-economic challenges. I'm sure you can actually accept to that because ever since we've had COVID-19, we've been having various challenges whereby we've also been having lockdowns And this have actually had an impact in the community, and also with regard to socio-economic status. So far, no drug has been found conclusively to be a cure or prophylaxis for COVID-19. And then going back to our vaccines, so these are the type of vaccines that we have: the Sinopharm, the Sinovac, the Covaxin, the Sputnik, the AstraZeneca, the Johnson & Johnson. But in the city of Bulawayo, we are mainly giving the Sinopharm and the Sinovac. So those are the drugs that the medicines, the vaccines that we have in Bulawayo. And then looking at our roadmap of COVID-19 vaccination, if you remember, we started with the frontline workers, where we're looking at the healthcare workers. And our media houses were also in our frontline. I'm sure you were one of the first people that were also vaccinated. Huh? You remember we got vaccinated in Northern Suburbs districts, and most of the media personnel were actually there. And then also the ZLP and the military were also at the judiciary in the front line. And of course our teachers, because of their exposure and the number of people that they also interact with. And then we later rolled out to those with chronic conditions and the elderly, because as I mentioned earlier on, that they are also at high risk, and looking at our admissions, it's mainly those with chronic conditions and elderly that were getting the severe symptoms, and hence they roll out to them. And then we also moved on to the traders and vendors. They are always in the street interacting also with various exposures, actually high. So we also moved on to the traders and the vendors. And the general, then later on we moved on to the general population above 18 years. And then we also came to the 16 to 17 years age group and the 12 to 15 years age group. So our rollout for the 12 to 15 years age group, the City of Bulawayo, in conjunction with Ministry of Primary and Secondary Education, Ministry of Health and Child Care, together with various partners, we conducted a vaccination program targeting the 12 to 15 years age group. And a lot of people were wondering why the 12 to 15 years age group, is it safe? So based on the available scientific data, in line with the Medicines Control Authorities of Zimbabwe guidance, the specialist pediatricians further recommended the vaccination of the 12 to 15 years old age group. So whatever comes into the country, we don't just give the vaccines, it has to go through the Medicines Control Authority of Zimbabwe, so that they also make their own assessment. And the specialist pediatricians also came on board, and they actually recommended that the vaccine was safe for the 12 to 15 years age groups. And then meanwhile, during the campaign, the vaccination of the 16 years and above age group continued. So our vaccinations were mainly in our own municipal clinics that I mentioned earlier on, and then the central hospitals, the Mater Dei Hospital, all primary schools and secondary schools, because remember, most of these age groups are actually found in schools. So we used both the school-based model and also the health facility model. And then we also had our outreach points. Why our outreach points? Because we also actually noted that most of the clients were no longer coming to the health facility, and hence we decided to do the outreach points, where we actually vaccinated a lot of clients there. So our first round for the 12 to 15-year-old, it was from the 21st of March to the 4th of April. I'm sure you remember we did the sensitization when we started our first round for the 12 to 15 years old. And then the second round, we started on the 2nd of May, and it's ending on the 17th of May 2022. And it does not mean that we're going to end there, but we will go even beyond, we will continue vaccinating. And then what was our performance as of 4 April after our first round? So that's for the dose one, the 12 to 15 years old. Our target was 64,588, and we managed to vaccinate 34,902. and our coverage was at 54%, which is quite low, really. We're expecting that at least we should vaccinate more than, at least get to around 70%. So it was really low. And the 16 to 17 years, remember those we started earlier. So our target when we started the campaign was at 28,225, but we only managed to vaccinate 4,380. That was the 15%. So this was just during the campaign. And then, like we said, that the 16 years and above, we continued. So for the 18 years and above, the targets, those that were not vaccinated during the first round of our campaign, we were looking at 176,169 people, and we only managed to vaccinate 5,848, which was the 3%. But I'll go on to give you the overall vaccination of the 12 years and above in the city. So the target for the city, that is the dose one that I'm talking about, was at 268,982, and we only managed to vaccinate 45,068, which is quite low. That's why we are here, so that we map the way forward on how best we can actually assist each other to market the vaccine and ensure that people are vaccinated, at least reach 70%. And then as a city, that is as of the 5th of May 2022, this is for the nation, but I'm mainly going to talk about the city of Bulawayo. So our target for the city of Bulawayo of the 12 years and above is 569,010. And so far for dose one, we have vaccinated 348,007 people. Our coverage is 61.2%, which is still quite low because we've been there for quite a long time. Those that have been following our seed rep, I'm sure you'll note that we've been stagnant for quite a long time. So that means we can still do something. Though we are tops, we are no longer tops. We used to be tops. I remember when we were giving the feedback, when we were sensitizing on during the first round, we were at around 59%. So that means we haven't really gone up. So there's a lot that we can do. Together we can, isn't it? So we are at 61.2%. And then for those two, we have vaccinated 271,911, and we're at 47.8%. Remember, I said at least we should be at 70%. And then for those three, it's even worse because we're supposed to be getting our booster doses. How many of us have had their booster doses in here? Okay. Thank you. Sorry? We are the advocates, eh? So we should be frontline people to get vaccinated. So that at least we can be able to convince other people to get vaccinated as well. So as a country, we are looking at it's 11,239,749, and we're at 52.3%, which is still quite low. And then our dose two is even worse at 33%, and dose three, the booster doses, we're still not doing well on our booster dose. And yet COVID-19 is still there. Dr. Mpiswada is going to talk about our situation as a city and also as a country with regards to the cases of COVID-19 vaccination. So COVID is still with us. So we really need to do something. That's why, like I said, we are here so that we can make the way forward on how best we can boost our coverage. And then with regards to achievements, as a city, we have received a lot of support from partners and also, of course, the media houses. You've been reporting positively about COVID-19 vaccination, and we really appreciate the support that we've been getting. And we've also been integrating services. I'm sure you're aware of the cholera in Zambia and also the measles outbreak in Manicaland. So that means we should not forget about other conditions that are still there, those that have the chronic conditions. So we've been integrating. We're not only looking at COVID-19. And then we've also been using various communication channels with the assistance from the media houses as well. So those are our achievements as a city. And then challenges, we continue to face COVID-19 preventive measures, burnouts. You'll notice that people are no longer wearing their masks. It's either they are not wearing them properly, even physical distancing. Lapa, is there any physical distancing? It's not there. So what does it mean? It's there for some of you, but some, that's quite sure. So I think there's burnouts. So yeah, we really have a serious challenge. But COVID-19 is still with us. So that means we should continue talking about the COVID-19 prevention protocols. And there's no physical distancing observed, specifically in bus queues and shopping centers. Huh? And then social activities continue. And the backyard market stalls, of course, the stigma and discrimination and the infodemics. The infodemics, the media houses are here to assist. So I'm sure we'll continue reporting positively about COVID-19. You remember when it started, when they talked about the vaccination, after 2 years you'll be dead. You remember? And what did we do as media houses? That is not true. We do respond positively to that. You did? Awesome. So those are our challenges with regards to COVID-19. And then what then are we recommending? That we should continue sharing information on COVID-19 preventive measures. Remember, I said COVID-19 is still with us. So we should continue talking about COVID-19 preventive measures, including COVID-19 vaccination. And then we continue to maintain engagement of the law enforcement, and then to keep on providing social support to the infected and affected, because we said COVID-19 can affect anyone. So let's continue supporting those infected and affected. And then with regards to information, to use the recommended websites, and mainly is the WHO, the CDC, and of course our UCC website, Ministry of Health and Child Care website. And then we should also combat stigma in all forms and all groups. And then the solidarity and awareness, I think, is the most critical.
I won't introduce myself any further. I'll just take this time to run through the update that is long overdue, isn't it? So you'll find that we know that there's been COVID all this time. Since, for Bulawayo, it's since the 7th of April 2020. And we've been following up the outbreak, not just on our own, but also with the community working together with us, isn't it? Together with all of us as stakeholders. But there's what we call emergency response mechanisms, which have been at play for a very long time, even up until the outbreak started. And together as pillars called epidemic preparedness and response pillars, we've been following up these outbreaks so that at least they can be contained. So we've been working together to intensify these emergency response mechanisms for all these pillars to detect, contain, monitor, predict, and manage the COVID-19 outbreak, as well as other outbreaks that sometimes emanate. Like sometimes we usually have the diarrhea outbreak, and then we're also on high alert for some outbreaks that are in neighboring areas, which we'll just touch a little in the next slide. And then we are doing this as pillars in order to leverage on COVID-19 response, so that we're able to strengthen our capacities as we prepare for action, isn't it? So as a province, we know there's COVID, and we are also on high alert for wild poliovirus type 1, because it's currently evolving in Malawi, right? And then we're also on high alert for cholera, because it's currently evolving in Zambia. So since it's neighboring to us, we are actually very concerned, and our mechanisms are already ready. We are already preparing for the inevitable in the event that it gets here. And then we also know that there is Ebola in Congo, and because of the inter-country travel, we have to remain on high alert. And then we know that in Zimbabwe, we have some provinces where typhoid is endemic because of the intercity travel. you find that as pillars we're also working together in order to contain this. And then we've been having COVID for some time. Before I run through the figures maybe, I'll touch on what we've been trying to do. We've been trying to reduce the transmission of COVID as these pillars, which I'm going to unpack after this slide. We've been trying to interrupt the chains of transmission through the activities as the pillars. We've been trying to come up with mitigation plans so that we're able to provide essential services to our community as we respond to COVID. So we're trying to do everything in the context of COVID-19. We're trying to accelerate also COVID-19 vaccination. I'm sure we've heard a lot about that, so that at least we prevent severe kinds of COVID in our symptomatic COVID patients. And then we've also been in the process of putting in place early warning systems in the event that COVID is detected in some places. We want the presence of early warning systems in place, which we've been working on through these same pillars. We've enhanced our surveillance and testing, and then as a country we've also started sequencing, although not much. We're still outsourcing some of the service so that we know the strains that are currently evolving. And then we've been trying to look at risk-based approach to international travel, where we need people to be tested, we need people to be vaccinated as they travel, so that at least we avoid moving the infection from one area to the other. But what we try and do is update our information with the real-time data so that we inform people and communicate evidence-based information that can help us change the situation. I believe as long as people have the correct information, then it becomes easy for them to change their behavior in view of what is happening around. But we've been noticing that as we detect these cases, there are a lot of psychosocial issues that come about from both our patients as well as the workers who handle these patients. So we're integrating the COVID-19 response activities with the mental health and psychosocial support as well. So I keep referring to pillars. These are the pillars that are currently responding to COVID. So it's not just maybe one person doing it. We're a very big group of people that work together. We believe we belong to one hand, that is the 5 fingers. So now that there are 11 pillars and there are 2 hands with 10 fingers, I don't know which one will catch them. But anyway, we are working together as the 2 hands, or I can say 1 hand, to try and contain outbreaks that come up, that are detected in the province. So we have the coordination pillar, which assists us when it comes to the matters of collaborating even with the stakeholders, the matters of coming up with, it works very closely with the logistics pillar, which is number 8 over there, where they're trying to assist us maybe in coming up with resources such as maybe premises where we're going to admit our patients, resources that we're going to use to follow up these patients, that we're going to use to manage these patients. All this is logistics and coordination. They have the call-out list in the event that we have a particular outbreak. They know which premises maybe we are going to use, which flow chart we're going to follow, and this works also closely with case management and infection prevention control. When cases have been detected through the laboratory pillar, which is the testing, that's number 3. But for those cases to be detected, they have to be followed up, and a system should be in place for high alert, and this is done by what is called the surveillance pillar. And then we have the risk communication and community engagement pillar, which is there to inform the community on the status quo, to give the key messages on how we can maybe manage the outbreak. I'm sure they can unpack the rest as they are the gurus in risk communication. I'm just a surveillance pillar lead. And then we have the point of entry pillar, which is not active in Bulawayo since we are not a port of entry. But we work very closely with our March North and our March South provinces, who are the ports of entry. And then we have pillars such as monitoring and evaluation, as well as operational research. These are actually cross-cutting, because we have a lot of operational research work that is being baked, it's being done, and it cuts across all the pillars. That is assisting us when it comes to acceleration of vaccination activities. So I'm sure some have seen this global evolution diagram of COVID-19. So maybe for the benefit of those that haven't seen it, before we run through the figures from our global level coming down to where we are, if we look at this, I numbered it so that we can be able to follow closely what happened in brief when it comes to COVID-19, right? I was saying COVID-19 emanated in China, where a cluster of cases were detected. That was on the 30th of December 2019. That's our number one, isn't it? Are we together so far?
Yes.
Okay. And then our number two, investigations had begun, right? We had people who had similar kinds of symptoms, they flu-like symptoms. It was a group of about 44 people. So then when they were investigating, they discovered that what they had in common was a visit to the Wuhan seafood wholesale market. So they closed it so that it can be investigated further and tests could be done to find out what could be the problem. Then they discovered that no, this is actually a new virus. Novel means new, that's number three. A new coronavirus is affecting these people. We've never seen this kind of flu. What is it? So we call it the novel. Initially, remember, it was called the novel coronavirus. So the novel coronavirus was isolated. This was now on the 7th of January 2020. Look at the space of time between the two. That's the idea, to see how fast this thing has been spreading. The cluster of cases first, it was an outbreak. And then now we're looking at it spreading to other areas. It becomes an epidemic. And then eventually it spread to almost all the continents in the world. Now it became a pandemic, but over a very short space of time. Maybe just to run quickly through it. On number 4, stage number 4, milestone, stage 4 on milestone number 4, we had our first fatal case reported. The first COVID-related death was reported on the 11th of January. And then on the stage number 5, sequencing had been started, and then they designated the 2019 novel coronavirus, which is now called Covid-19, isn't it? And then from there, the first case was reported in Thailand, and in no time, by the 16th, a case was reported in Japan. This is because of people who what? Are traveling. And look at it now, people are still doing what? Are still traveling. But I'm saying, as you travel, our outcry is please remember to implement the preventive measures, right? It's best to just prevent. But people tend to let their guard down and forget as they travel and end up spreading. So you'll find that from the 13th to the 16th, it had spread to Thailand and Japan. And stage number 9, this is now the 19th, from the 16th, 17th, 18th, 19th, 3 days later. The first case was being reported in Korea, second case in Beijing, one case in Indonesia. Can you see the short space of time? It's quite disturbing. And then we had our first healthcare worker who was infected on the 20th of January 2020. And then milestone number 10, China already had all the provinces but one affected by COVID. And then our stage number 11, we come home. We had our first case reported in Victoria Falls. Remember, it was imported. So our first case was reported, that was 15 March 2020 in Zimbabwe. And then for Bulawayo, as I had mentioned earlier, we had our first case on the 7th of April 2020, though the specimen was collected on Friday the 4th. There was a lockdown and testing was still being done centrally in Harare. So we sent the specimen on Monday, results came out on Tuesday. And unfortunately, it came out posthumously. He had died on the Saturday. And then let's come down to the figures. So since then, since the cluster of 44 cases in China, and our first case on the 4th of April 2020, COVID has actually been evolving. And it's been evolving very fast. So globally, as we speak, as of this morning, this is where the cases are. It's 515.9. Serious, eh? And look at the deaths. It's too much, eh? We're losing a lot of people. It's at 6.2, but at least our recovery rates are still at 91.24%. But what we worry about mainly are the active cases. You see the active cases. Let's take note of those as we go down. Take note of the deaths, take note of the active cases. And then if you look at this part in brackets, this one, you see my arrow. It doesn't show them. The CFR, it's just simply, the case fatality rate is simple. It just tells you, it gives you a picture of whether the number of people that are dying versus the number of people that have tested positive is too high or is too low. So it helps you measure also. And so if it's below 1%, you know that you're good to go. So globally we're at 1.2%. Not quite, but it's better than where we're coming from. But we're not celebrating yet. We wanted to be at 0, although it's not possible. But it may be soon enough. But it's still at 1.2. Let's look at what's happening as we come down to the national level from the global level. And then in terms of our vaccination, it's still good. It's at 65.64%. As we come down nationally for our COVID cases, I'll go back to the other slide after we finish this flow one. So nationally, this is as of last night, according to the Zimbabwe Ministry of Health and Child Care National Seat Rep, which is shared daily. We send in statistics at the end of each day. It's compiled nationally. It's coming from all the provinces in the country. And then this is what came out yesterday. We had 100 new confirmed cases. So my worry is that the attitude out there has changed. You find that people are saying COVID is failing, but it's not finished. It's still there. Yesterday we had 100 new cases, pushing us up cumulatively to 248,150 cases, as you can see there. And then this is nationally, and then for the whole of Zimbabwe. And then for our deaths, we had 1 new COVID-related death nationally that was reported from one of the provinces, but not ours, thankfully. And then for the deaths cumulatively, so we're now at 5,472 deaths so far. And if you look at it this way, our case fatality rate is how far is it from 1? It's at 2.2. It's still on the bad side, but not too bad. And then for our recoveries, our recovery rate is at 97.5. So it shows that at least for our recoveries, it's not so bad. And then for our active cases, we're at 739 active cases as a nation. For our vaccinations, dose 1 is high, it's at 52.3, dose 2 is 33.0, and our booster dose is at 5.5%. Then let's come down to our Bulawayo. This was as of yesterday, and as of yesterday we reported a total of 26 new cases. Do you know that yesterday, of these 26 cases reported in the last 24 hours, Bulawayo had the highest number of cases in Zimbabwe? This was yesterday. So fortunately, we did anticipate this, that maybe after people have come from holidays and from celebrations and these big occasions where entrepreneurs come together, they shall remain nameless. You have people letting their guard down. Yeah, so people tend to relax and let their guard down. So we anticipated this, and now we've had schools reopening. So we are bound to pick up more cases, but now we're picking them up because people tend to relax and risky behavior still continues, which is our main worry. So we're 26 new, and we topped the charts because I think the next one should have been about 10 or 7 in other provinces. We were the highest. And then in terms of our deaths, thankfully we didn't have a COVID health reported yesterday. So we're still at 867 deaths. But look at our case fatality rate as a province. It's disturbing, and it's at 4.2. And we said the mark is what? It's 1. And so at 4.2, it's showing that we have a serious challenge. And then for our recoveries, we reported 7 new recoveries. So in terms of our recovery rate, we're at 95.4%, which is still not bad. Why? Because we were saying if you've completed your isolation, which is 10 days if you don't have symptoms, and you survive, then you are considered a recovery, even if you may still test positive, and if you decide to retest, but it's no longer recommended to retest. And then leaving us with 93 it's actually supposed to be 183 active cases, not 93. And then in terms of vaccination doses, as you can see, we have the 60.7, 47.1, and 6.1 with a positivity rate of 2.1%. Let me go back to this one, where we had said we're on high alert for these and for these other outbreaks. So you'll find that in Malawi, the wild poliovirus type 1 was declared in February 2022, and already they've detected 12 positive cases. Their positivity is at 23%, and it has affected 29 districts. It's quite disturbing. And so as we look out for COVID, let's also be on high alert for all these other conditions so that we are not found wanting. Zambia is currently on high alert for cholera. As I mentioned earlier, it was declared on the 11th of April 2022. Currently, it has 8 confirmed cases. So in terms of positivity from all tests that have been done from the stools collected, it's at 44.4%, which is also quite bad, isn't it? So it's not just COVID. And then I was saying, since COVID started, this is what the cases are looking like. This is from when COVID started in Bulawayo. This was on the 7th of April 2020 up to yesterday, which was the 5th of April when we had our last data. We can see that. Huh? So it's date of diagnosis at the bottom versus the number of cases. So this is a simple epidemiological curve which shows where our cases increase when they increase, where they decrease when they decrease. We can see that. Huh? So normally, under a normal outbreak, instead of date of diagnosis, we would want the date of onset when someone became ill. But here you find that some people don't feel anything, they are asymptomatic. So it was agreed that instead we use the date of diagnosis. But what I wanted us to take note of, maybe as a take home from this epidemiological curve, just to simplify it further, is this part. If you look at this, this is the same diagram, right? But if you look at it here, we are now looking at the peak for each. The peak gets higher each time. Huh? You can see that. Remember, they were saying there was wave 1, there was wave 2, wave 3. So people like to call them waves or stages. So we have our first stage there. We're not counting this one because here we had an accumulation of specimen in a lab. It was run the same thing. It made it look like it, but our peak was there. We had 51 on average for wave 1. Wave 2, we had 110. Wave 3, we had 358, and then wave 4 with 679. And we were saying to the public, they need to see this, they need to know, they need to appreciate that if you allow COVID to keep evolving, it gets worse with each wave. Let's not allow it to get there. Because if it gets there, it may be worse. If you look at this wave, it was more vicious than all these others, and the third one, right? And then we're saying here that it was now the only one. It was no longer as severe as this, but we don't know what wave will come with the next variant. So people need to be careful. If you can see here, it has started increasing. Can you see? We're in serious trouble, right? So it increases, it decreases, and all those increases and decreases have names. So I don't know what you're thinking. Or scar happened. No, it's fine. So in the next one, it's just a diagram showing us the names of what we call it when it actually decreases. When it increases, people call it waves or surges, but those scientifically are called exponential phases, right? And then when they decrease, it's the deceleration phase. Then we have the stationary phase, we have the lagging phase. So I just wanted us to maybe have a visual appreciation of it. As we isolation facilities in Bulawayo, as of last night, we have Thorn Grove Hospital. It's an isolation facility also for COVID patients. We currently have 4 patients that are admitted there. And of these 4, it's nice to know how many of the 4 that have been admitted are actually vaccinated. You'll find that of those, only 1. So maybe before we run through that one, this is the diagram I wanted us to just see. We're coming from this one, and then we say to magnify the peak, you can see there is uniformity there. There's an increase somewhere in cases. You can see it there as the cases grow, it becomes more intense with each wave. And then in terms of symptomatology, the third wave had the worst compared to the rest of the waves. And the symptoms have been changing. We've been picking new symptoms as we went on. Now we even have guys who say they are constipated, some have diarrhea, and yet still have COVID if you screen them. Right? So this is the one I referred to, where these phases also have names scientifically. It wants another presentation altogether, but just to appreciate where it goes up, the surges is the exponential phase, and then after that, it's just the life cycle of an outbreak. It decelerates. It doesn't just decelerate on its own. The rate of deceleration, which is the reduction of the cases, is caused, the reduction is caused by the activities that are supposed to be correcting that measure, the mitigation measures through the emergency response mechanisms that we spoke about earlier, not alone, but with the stakeholders, with the community as we work together to reduce and remind people out there that preventive measures still work. Some people think if you are vaccinated, it means that you no longer get COVID, you can do what you want. And they were asking one time to say, so why are we still wearing masks in Zimbabwe? What is wrong with Zimbabwe, you know? Right, so I had spoken about our admissions. I think of note there is, we are still admitting COVID patients. And now seeing that we have about 183 active cases, we were saying that we want to contain them by admitting these patients. We are facing a lot of resistance. We are facing challenges where sometimes when we receive results of positive patients and teams are supposed to be following these people up at home, they'll find that is the wrong address or that address never existed before. So we have an outcry to the community so that at least they can see the importance of containing this outbreak, because it looks like some people are not taking it very seriously. As the teams are going there, they are finding people not at home, they're getting wrong addresses. There's this one time where a team was visiting a particular family. They got to the family and found a crowd of people coming to crowd to see the rapid response car at the location. So everyone was now coming to crowd at the house of the COVID patient, which is already a hazard. Right? So now, unfortunately, the person who had been reported as a case had put the correct name, right, but the wrong address, took the neighbor's address. So when the team are saying, we're looking for so and so, do they live here? The people, they were saying, no, but that child who's running there is running to the home, that child who's running out. And so they had to follow the child to that house and found the case about 3 or so houses away. He had given the neighbor's address. So some do it intelligently, which is not so intelligent, of course, and give incorrectly give an incorrect address, which is very wrong. But in some instances, we have some whom we catch and some who will still be admitted, and we found the facility to say, no, this person can't be found. Talk to the patient until the patient divulges the correct address. So we really are asking that people give us correct details so that together with the community we can work together to contain this outbreak. And we are moving them. So now we're thinking that maybe the best strategy would be that when they test positive, they must quickly be isolated before they even go home. Maybe we should go that route, don't you think? You're laughing. Okay. So for our patients, as you can see, in terms of vaccination status, for Thorn Group, we had 4 admissions as of yesterday. Of the 4, only 1 was vaccinated. So we still have some people that are not vaccinated. So we can't stop talking about it until we've actually reached our point of saturation and everyone has been reached. And then for UPH, we currently have 2 admissions, but we're still waiting to hear about their vaccination status. It's still unknown. Mater Dei has 1, and then Ewusileni has 7, and then of the 7, 3 are not vaccinated. So it's worrying when you're seeing that some Bilo currently has 2, or still also waiting for vaccination status. For Mater Dei, I think I'll double check, but I think that one is vaccinated. I just forgot to update. And then, funny enough, we still have more females that are being reported as cases compared to males. And for deaths, it's still the same. We still have more males that are dying compared to females due to COVID, even up to today. So I'm going to skip some of these things and then maybe come to the institutional outbreaks. So you'll find that when, since COVID started, we've noticed that when we have some of these, what can I say, institutional outbreaks, it's usually at occupational settings or institutions of learning. It has been intense, and the key drivers there have been low risk perception and risky behavior. So here, since schools opened, they opened when? A few days ago. We already have cases there. So they opened a few days ago. So we already have 1 case from a tertiary institution, and we already have 1 case from a primary school. So as I speak now, as I was coming in here, from one of the primary schools, this one primary school that has been affected, we've detected 2 secondary cases from that same school. So now we're going to test the contacts of those and see if we can contain it before it goes further. So in essence now, in the last few minutes before I came in here, the number went from 1 to 3, and so we have our first schools that have been affected since a few days ago. So we're in for a high German. So we need to really impress also upon our children to mask up all the time, to implement the preventive measure, because we want to learn to live with COVID. And as long as we cannot learn to live with it, most of the systems will shut down completely, and we want them to keep moving. So in essence, it means that we have 50-50 in terms of the number of cases that have been affected in males and females. So if you notice, when we started, there were no cases until you saw that graph. So there's always a transmission scenario. Then eventually we had sporadic cases, we had 1 or 2 cases there. Then eventually we had clusters of cases. Now we're at community transmission. We've been at community transmission level 4 for some time. So our job now has been to slow transmission, reduce the number of cases so that we end the community outbreaks. So together, we are hoping that we'll be able to achieve the same as all the pillars work towards scaling up emergency response mechanisms, enhancing them, and intensifying all our response mechanisms. And then time and again, we conduct risk assessments. So most recently, we conducted one on the health workers themselves, so that we're able to see where the infection is coming from for those that have been affected, how intense it's been, what it is, where we missed it, which system we need to actually improve on. And then in terms of the challenges that we've been facing, mainly it has been the inadequate material. So you'll find that sometimes we have shortages in cartridges that are used to conduct PCRs through the gene expect machine that is at Thornbrook, and it becomes difficult to actually test for COVID. We use rapid antigen test kits, but there are some instances, especially for Bulawayo, where we're saying our algorithm is that if someone who has symptoms tests negative on rapid antigen, we want to verify the negativity with a PCR. So we normally, for a quick turnaround time, we would want a gene expect machine to be used, and sometimes we run out of cartridges. At the moment, we still have some, but we would really appreciate if we had supply for cartridges for COVID. And then human resources, yes, there's a higher staff attrition rate as people look for greener pastures. No matter how fast we are trying to recruit them, we wish there was a carrot that could be hung on so that people can keep wanting to stay and come back. And then in some, you'll find that we've been receiving some patients with serious major patient characteristics, and they deteriorate and need ICU facilities. There are currently no facilities that have been developed or designated to accommodate ICU patients that need ICU, and there's also a need for staff and infrastructure in the event that these ICUs are actually set up. And then also of major worry are the illegal activities that seem to be on the increase. Everyone is trying to survive, but unfortunately all these keep driving transmission because there no COVID protocols are observed. You find that there's also abuse of substances where instead of sanitizing, someone wants to smoke or drink a sanitizer. So it becomes difficult now to talk to the children. And then so there's need to intensify enforcement. Our security pillar is trying to help us there. We still have infodemics, despite the fact that COVID started long back, and while now moving to the third year, we still have problems with infodemics, and RCC is working flat out to address these issues. And then for some instances, we have poor health-seeking behavior in people, especially in the third wave. Someone would die in an ambulance, and you ask yourself, okay, did they just switch off, or they had been deteriorating at home and sitting and waiting for the worst-case scenario, that's worse than worse, before they can be moved, which was very depressing. We lost even some of our own, and it was quite a very, very touching moment. We needed a situation whereby the community could see what people were going through in the isolation facilities. They were so packed. When the research facilities become so packed, they can't even accommodate enough people. So it was now people had to be accommodated, especially those that need oxygen. And then you had to create even floor beds so that everyone can be accommodated. And yet people still don't want to adhere to preventive measures. And we don't know what to do to convince people to see that it is important to implement preventive measures. We are not sure what else to do except to keep teaching and teaching until someone starts singing the song even if they don't enjoy it, and which is generally the idea. And then sometimes we have patients that develop dialysis problems and may need some assistance or intervention in terms of hemodialysis, yet they are COVID positive. And there's currently no facility that supports that. And we're saying that has been a major challenge, where maybe some patients have been lost, some renal patients have been lost because of failure to access these services. You now have to do it maybe outside Bulawayo, you have to be sent maybe even to Harare at a particular cost, and you can't even afford, and you die because you have no money in your pocket, which is sad. I was saying if there could be a designated facility, because now all those pillars you saw there, there's no one who's actually paying anyone to do anything. That's a calling, that's our duty. We do all that response for free. And so I was saying if there could be that kind of facility also that can accommodate people, so that even those that cannot afford can be able to access the service. And then there are some private players who've been participating in vaccinations, and we're saying we wanted them to be able to reach out to more numbers compared to what they are doing. And then you'll find that in some sectors, like the government sector, some health workers have access to insurance. We're saying that it would be nice if that could be rolled out. So we're lobbying for the same model. This is through our logistics pillar. We don't know if that will work, but it's just a suggestion to say if it works, it would be an added incentive to the workers, including the red zone allowances and things like that. Right? Okay, so this is just a short SWOT analysis. So in terms of our opportunities, we've noticed that there's actually improved coordination and communication across all sectors. You find that with some sectors we never used to engage, but all of a sudden, since COVID started, we all seem to be working together. And we pray that it continues that way, because that's one of the good things that developed because of COVID, and the multi-sectoral collaboration. And then we want to be integrating COVID-19 with all the other response activities, like integrating cholera case management, etc., with COVID-19 and training, especially for health workers. And then we also want the regular training, especially for health workers, on how to use the PPE, infection prevention control, and integrated disease surveillance and response, so that we are prepared for these other outbreaks that may come if we are not careful, but we just want to prepare.